Thank you so much for having me. I'm really excited to be here and talk with you all today about trauma exposure and PTSD from a lifespan developmental perspective. We really focus on diagnosis, assessment, and treatment with older adults and veterans, military veterans. My name is Anica Pless Kaiser. I'm a clinical psychologist at the National Center for PTSD at VA Boston Healthcare System and an assistant professor of psychiatry at Boston University School of Medicine. And I just want to acknowledge our funding sources, the veterans, military veterans who've participated in the clinical work and the research activities. We have funding through the U.S. Department of Veterans Affairs and the Office of Rural Health. And I also want to acknowledge my collaborators and have provided some additional reference material, but feel free to contact me if there's any additional information I can be helpful with. So today, the talk that I'll give is a little bit of a sort of review and then talking about some of the work that we're doing at VA Boston. So we'll talk a little bit about trauma and PTSD diagnoses in older adults and military veterans. I'll talk a little bit about the prevalence of PTSD in late life and describe some risk factors for reemergence of PTSD in late life, as well as assessment measures and considerations and information about treatment approaches as well. And if we have time, I'll talk a little bit about PTSD at the end of life and some of the work we're doing there. In terms of trauma exposure, we're talking about exposure to actual or threatened death, serious injury, or sexual violence. That's defined by the DSM in terms of what, excuse me, what's considered a traumatic exposure. These traumatic experiences can be directly experienced, could be witnessed, could be someone learning about one of these things happening to someone close to them in a violent or an accidental way. Or it could be in terms of being repeatedly exposed to extreme traumatic experiences, such as in the case of first responders or military personnel. In addition to trauma, a traumatic experience, to meet criteria for PTSD, according to the DSM, a person must experience symptoms across several symptom clusters. So I won't go into a lot of detail, but the different symptom clusters are re-experiencing, having unwanted memories or dreams of the traumatic experience, avoiding reminders of the traumatic experience, having negative cognitions and mood. So this is having self-blame or distorted cognitions about the traumatic events, or having a difficult time remembering important parts of the experience. Or really having some difficulty experiencing positive emotions, or feeling detached from others, as well as increased arousal. So this is your typical irritable behavior, hypervigilance, exaggerated startle response, difficulties with concentration, and in addition, having functional impairment and clinically significant distress. In terms of PTSD, according to the ICD-11, there's PTSD that includes the core clusters of PTSD, re-experiencing avoidance, hyperarousal, and then complex PTSD that includes some of the additional types of symptoms that we've talked through. So this, it looks like this figure didn't so much translate in terms of in the formatting, but I think this is something I don't need to tell to this audience. That it's one reason that it's important to look at trauma exposure and PTSD in late life is because we're having growing numbers of older adults, and that trend will continue over the next few decades. So not only are there more and more older adults, but these older adults are likely to have experienced at least one traumatic event over the course of their lifetime. So about 70 to 90% of older adults have been exposed to at least one potentially traumatic event, and older military veterans are at particularly high risk for experiencing multiple traumatic events. Another reason this is important is that relatively less is known about older adults with PTSD. And I do want to clarify what I mean about late life PTSD. And so we're talking in this context about adults age 65 and older, but there's really a lot of variability in what studies consider late life. As you're all likely aware, many studies say that they include older adults, but really don't have enough older adults to be age representative. And so there's relatively less known about PTSD in general in older adults and veterans. And many of the studies that have been conducted on PTSD, whether it's assessment studies or treatment studies, either exclude older adults or don't include a significant enough number of them to make age comparisons. And until recently, there wasn't a requirement to do so. And a final reason that understanding PTSD in late life is important has to do with the clinical impact. So when the impact of trauma history and PTSD symptoms is under-recognized, it is going to be undertreated. And that the misattribution of symptoms can have a negative effect across different life domains. And really, the recognition and proper diagnosis allows for appropriate treatment planning and really allows for an individual to be able to make meaning of their difficult or traumatic experiences, which can be an important late life developmental task. I'll talk here a little bit about the prevalence of PTSD in late life, as well as the clinical presentation. I do want to make it clear that despite the high prevalence of trauma exposure, the majority of people who do not go on to develop PTSD. So 12-month prevalence ranges from 0.2 to 0.6 across studies. I'm sorry, 0.2 to 2.6% across studies. And lifetime prevalence being about 2.5 to 4.1% in older adults. Now, that the rates are higher among treatment-seeking older adults and veterans, as you would expect. These lines represent trajectories that we see clinically, some of which have been documented in empirical literature via longitudinal studies. But some of the typical trajectories that you might see in terms of PTSD symptoms are a sort of a resilience trajectory, or having relatively no PTSD symptoms, or we've seen delayed onset PTSD symptoms, where symptoms don't develop until later life. The third line is having symptoms immediately in the aftermath of a traumatic event, followed by a decrease in symptoms, followed by a later life increase in symptoms. There's also decreasing symptom trajectories as well as a pretty chronic trajectory that some people fall into. It's also important to point out that many older adults may not meet full criteria for PTSD. They may have trauma exposure and have some symptoms of PTSD, but have the subthreshold or considered subthreshold. And one of the important things to point out is that studies have documented functional limitations among people with partial or subthreshold PTSD. So something to consider in terms of possible interventions. So there are many reasons why older adults may start thinking about their older adults or veterans may start thinking about their past military experiences or their past trauma experiences. And one reason really relates to engagement in a life review process in terms of Erickson's integrity versus despair conflict and engaging in life review. In addition, normative life changes really can trigger feelings related to earlier traumatic experiences. So any kinds of role loss, so retirement or changes in social networks, social settings, family roles, having increased medical problems or decreased functional or mobility status, anything that can prompt feelings of loss of autonomy or control. Obviously, bereavement or even just having more time to think are all issues that sometimes bring up having more memories of past experiences, as well as any strong negative emotions, feelings of helplessness, pain, loss of control, can mirror earlier experiences of these emotions. And for some, cognitive difficulties may set the stage for having increased memories. So as one of our research groups at VA Boston has developed this conceptual model of a process called later adulthood trauma re-engagement that thus far has focused on older combat veterans who returned from their military experiences and ended up functioning fairly well during their midlife times. And as they grew older and confronted some of the challenges of aging, shall we say, in terms of retirement or any of the issues that I was mentioning before, start to have increased thoughts, memories, dreams, sometimes distress related to their previous military experiences. And this conceptual model really focuses on the processing part of these experiences. So thinking through the role someone played in the war and thinking through how they appraise their military experience overall, can either have a positive resolution and lead toward more positive outcomes such as growth or wisdom or acceptance, or may increase negative symptoms and distress and lean more toward PTSD, depression, substance use, suicidality. And so just before we get to the next part, I'll just say that our group, and I'll talk about this in a moment, but we've developed an intervention that can potentially help promote the successful resolution of what we call the later adulthood trauma re-engagement process. I did want to say a few words about assessment. PTSD in older adults. There's a number of factors that I'm sure you're all well aware of in terms of issues that may affect reporting among older adults or veterans, reporting of their experiences or their current symptoms, or issues that they're experiencing. Some of these reasons are really just sort of semantics, or that the diagnostic system wasn't in place to recognize PTSD for a long time. And so a lot of our older adults experienced traumatic events and related symptoms during a time where there wasn't a lot available in terms of assessment or diagnosis or treatment. In addition, there's always issues of stigma and cultural awareness of even what PTSD is, and how it may be treated and what kinds of services are available and what options there are. And then as well as comorbidities. So especially among older adults, PTSD may be misdiagnosed or related to some other medical or psychological condition that the person is experiencing. The person may not think to connect their current symptoms to events that happened 30, 40, 50, 60 years ago. And older adults, a lot of the veterans that we see end up presenting in primary care clinics rather than a mental health clinic. So those are some of the issues that can affect reporting and can affect getting people into services where they might be recognized or assessed even for their trauma exposure and PTSD symptoms. So one question then in terms of assessment is do our current criteria work well for older adults and older veterans? And so one thing to keep in mind is that many of the criteria and studies that are reviewed to develop the criteria are often developed with younger adults and then sort of extrapolated to older adults. So without some of the literature there, there's been some progress more recently, but we don't really know how well some of the criteria apply to older adults, and there is some differences in terms of presentations that are helpful to be aware of. So some people suggest looking at a lower cut point on your assessment measures when you're assessing older adults for PTSD. For some older adults, they might experience fewer intrusive memories of their experiences, in that they've had decades and decades to learn how to cope with these unwanted memories. And some veterans and older adults might experience decreased avoidance of trauma memories, and indeed be ready to approach and think through and process some of these memories. So they might be looking for people with similar experiences to talk to you about the impact of their experiences. So just quickly here, there's not a lot of research on our gold standard approaches for assessing PTSD, but in general, self-report and clinician-administered assessment tools are considered to be valid for use with older adults. So I just listed the National Center for PTSD website here. But in the interest of time, I'll continue on. I did want to mention the importance of considering comorbidities with PTSD in older adults, particularly cognitive issues, medical issues, polypharmacy issues. There's specific medications that are contraindicated for PTSD in older adults. Sensory, hearing, vision changes, pain or chronic pain, as well as depression, anxiety, other psychiatric comorbidities. There's a bit of a reciprocal or vicious circle sort of that can occur with comorbid conditions in PTSD, and that PTSD symptoms may arise that make it more difficult or increase avoidance of seeking treatment for comorbid conditions, and comorbid conditions may exacerbate some of the PTSD symptoms. So it's important to thoroughly assess for comorbidities as well. I'll briefly mention treatment for PTSD. So in the general population, psychotherapy and some psychiatric medications have empirical support for PTSD. I'll focus mostly on the psychotherapy. In the US and the Department of Veterans Affairs, there's several empirically based treatments for PTSD that have been rolled out. So prolonged exposure and cognitive processing therapy are two of those examples that have been disseminated in the VA. And there's not a lot of research with either of these treatments with older adults per se. There's a few RCTs now, and otherwise there's kind of case studies or uncontrolled trials with some positive findings and some mixed results as well. So there's still room there for additional research. There are also some RCTs of other types of treatment for PTSD in older veterans. So particularly narrative exposure therapy, integrative testimonial therapy, and spiritually focused trauma interventions have some support in the literature for older adults and with veterans. And really, just briefly, in terms of treatment, in terms of a treatment approach, the suggestion is really to perform a functional assessment to see what the impact of PTSD symptoms have been and are currently on the older adult, to provide psychoeducation about PTSD and build up coping and distress tolerance skills, followed by a discussion about if additional trauma-focused treatment or exposure therapy will be beneficial. And if the answer is no, or the person is not interested, to kind of continue with the cognitive behavioral approach. And if the answer is yes, is to continue with the trauma narrative and engage with PE or CPT or another approach. And overall, really, what can be particularly beneficial with older adults is to help facilitate meaning making and reconnection or re-engagement with their past experiences, and to provide corrective or new ways of thinking about past experiences. And really, the role of the trauma narrative is to put the trauma in a greater context of the person's life experience. Particularly with older adults, you want to try and decrease arousal as well as their avoidance, and increase, remembrance, feelings of natural emotions, allowing them to grieve if that's part of the process that would be useful, and to really witness and normalize this experience, and to acknowledge that exposure therapies are not contraindicated for older adults and older veterans. So I did mention that I would talk briefly about the intervention that our group has developed. We've developed the 10-session later adulthood trauma re-engagement group for older combat veterans. And this is really a psychoeducational discussion group that focuses on providing education about the reemergence of symptoms, coping skills, ways to engage in positive meaning-making strategies, and discuss post-traumatic growth and resilience, and provide space to discuss with other veterans with shared experiences. And we're continuing to conduct these groups. Our preliminary data indicate that there's high satisfaction with the groups and some reduction in PTSD and depression symptoms. We've mostly conducted these groups with US, Vietnam era combat veterans to this point, at this stage. And then briefly, I'll just mention some of our work that's funded by the VA Office of Rural Health, is to understand and develop resources and disseminate resources for hospice and palliative care providers who work in the community, who are providing care to older military veterans with PTSD, and to really understand what these providers are seeing and provide information about trauma-informed care. And so at this point, we've conducted a national survey with hospice and palliative care providers. We've conducted a bunch of interviews, and we've developed some videos to provide some education about the nature of PTSD at the end of life. And so we've been able to provide some tips in terms of recognizing PTSD and providing trauma-informed care. So part of that information will be disseminated via webinars and videos and handouts, and we're targeting providers, but also family members and caregivers of older veterans with PTSD, particularly living in rural areas, who potentially and realistically have less access to VA care. And some of the tips are really to validate and listen to experiences and memories that come up, to appreciate service, focus on strengths and resilience, and to provide education. And I guess one additional thing I'll mention is that in our interviews and surveys, we did see that providers are seeing PTSD symptoms at end of life, as well as some trauma-related symptoms that don't map on completely to PTSD, and maybe a little bit more general, such as restlessness and agitation. But that's been a really interesting project thus far. So with that, I will stop and thank you for your time and attention, and feel free to ask any questions or to get in touch with me at another time. Thank you so much.